this webinar the more. At ACI Associates, we are an advisory services firm that provides solutions in strategy, government relations, regulatory affairs, economic development, advocacy in various sectors, investment facilitation, policy analysis, and strategic investment in different sectors. Today, the theme of our webinar is improving women's health and preventing maternal mortality in Africa, prospects and challenges. And we have a sub-theme, which is the role of family planning in women's health. While welcoming all of you, I like to emphasize that the death of a pregnant woman due to complications related to the pregnancy or issues worsening some underlying condition or complication of management of such pregnancy is a very tragic event, not only to the family, but also to the service providers and everyone connected with the woman who suffered maternal death. Between the year 1990 and 2015, we all remember the Millennium Development Goal, where Goal 5 calls for a 75 reduction in the maternal mortality ratio across the world. And now, according to the Sustainable Development Goals, the global maternal mortality rate to be lower than 70% 100,000 live births by the year 2030. This is really a big target, especially for countries where maternal mortality still remains very high. And this is common in most African countries. Our leading cause of maternal death in Africa still remains hemorrhage and eclampsia. As part of build-up to the end of Millennium Development Goal, there was some achievement that we made in Africa. However, the achievement was not sufficient for us to make or attain the MDG Goal 5 in most parts of African countries. We only recorded average of -3 percentage point decrease annually. So for us to achieve the SDG in Goal 3, we need lots of action, and ultimately this our action could culminate in not only attaining SDG by 2030, but also eliminating preventable maternal mortality. So at this webinar today, we have eminent panelists from our country, Nigeria, Zambia, and Uganda, to discuss various issues of maternal mortality. So once again, I welcome everyone warmly, and I will quickly introduce the panelists so that we can conserve time, and when it gets to the turn of all the panelists to talk, I'll just invite them for their presentation. We have Cindy Chua, who is the National Program Coordinator for Sexual Reproductive Maternal, Newborn, Child, Adolescent Health and Nutrition Program in Zambia. Cindy, we're happy to have you. Cindy will be addressing us on global overview of women's health and maternal mortality. And the focus of our discussion will be more on reducing inequalities and improving investments on women's health to drive the progress of reducing maternal mortality across countries in Africa. Then we have Dr. Fumilola Olaolorun, who is a senior lecturer at the Community Health Department, University of Ibadan in Nigeria, And she's also principal policies and practices of maternal mortality reduction, and she'll be highlighting to us how to leverage data for policy and programmatic decision making. We also have the pleasure of the presence of Honorable Commissioner of Health, Kaduna State, Ajia Umar Katuna Hamid. She'll be discussing at this webinar, reducing maternal mortality, what works, and the way forward. We have recorded some experience and best practices. We want to learn what the experience has been in Kaduna State, located in the northwestern part of Nigeria. Dr. Asabe Bashir, the Honorable Commissioner of Health, Sokoto State, before we started this webinar, she was summoned to the governor's office on cabinet-related issues. But hopefully, she'll join us before we get to our turn or before the end of this webinar. It's expected to discuss the prospects and challenges of maternal mortality prevention with a focus on successful maternal health intervention and the use of data for decision making as well. Finally, the civil society play a very strong role in ensuring government and the people are taken accountable for their responsibilities and mandate. So we have one of the foremost CSOs in Uganda being present here today, Dr. Ben Kabiji. I hope I got your name right. You are most welcome. Dr. Ben will be discussing the roles of development time to the first presentation. So I'd like to invite Cindy, the National Program Coordinator for SRMN, CAH, and Nutrition Program in Zambia, to discuss on global overview of women's health and maternal mortality. Can we have Cindy's presentation, please? Cindy, over to you.
Thank you so much. I'm so excited to be here. Like you heard from the introduction, I am coordinating a national program on sexual reproductive, maternal and newborn and child health. And my role this morning is basically to just give a global overview of women's health and maternal mortality, but focusing so much on what we need to do for us to reduce inequalities and also see what investments we need to do for us to drive the agenda of improving women's health. So maternal mortality still remains a significant global concern. In 2020, we saw that about 287,000 women died during and following pregnancy and childbirth, and those statistics are alarming. And we have a target as SDG 3.1, which aims us to reduce maternal mortality to 70 maternal deaths per 1,000 live births by 2030. And looking at the statistics that we had in 2020, it means that we still have a long way in us achieving this target. And so 95% of these maternal deaths are occurring in low and medium income countries, which also includes Zambia and Nigeria and a number of countries within the region. And we see that 87% of these deaths are within sub-Saharan Africa and also South Asia. And also we note that sub-Saharan Africa accounted for 70% of the maternal deaths that occurred in 2020, while South Southern Asia accounted for about 16% of these deaths. And so, like I have mentioned, these statistics are alarming, and a lot needs to be done for us to be able to achieve SDG 3.1. And additionally, between 2000 and 2020, we saw that Eastern Europe and Southern Asia reduced their maternal mortality rate by about 70%. And this is statistics showing that about 38 to 11, which accounts for 97%, while 408 down to 134 respectively. So in 2000, we had 408 maternal mortality per 1,000 live births, and this reduced to about 70%. So despite having this high number of maternal mortalities in sub-Saharan Africa, we see that we also achieved a substantial reduction, which translates to about 33% between the period 2000 and 2020. We also see that a number of SDG regions, which include Eastern Africa, Asia, and Eastern Asia, as well as Northern Africa, reduced their MMR by about half, while Western Europe reduced their MMR by about 1/3. So the high number of mortality deaths is a reflection on the inequalities that exist when it comes to access to quality arts in the regions that are developed, as well as those that are still developing. May I have the last slide, please? May I have the previous slide, please? The one after this one, sorry about that. Yeah, so like I was already saying, we see that the richer populations have a lower number of maternal mortalities than the poor populations. And we also note that we have about 430 women per 1,000 live births dying in low-income countries compared to those that are in high-income countries where we have about 12 women dying per 100,000 live births. And also we see that there's a risk of death among women if you're coming from a low-income country as compared to those that are in high-income countries. And what this also means is that we have one person dying in 5,300 in high-income countries compared to one dying in 49 women in low-income countries. So the inequalities are quite clear, and there's need for us to bridge this gap for us to be able to drive the agenda of improving maternal mortality. So in terms of where these deaths are occurring, we see that most of these deaths being concentrated largely in the poor parts of the world and those countries that are highly affected by conflict. And in the statistics also show that in 9 countries where we saw crisis or rather conflicts happening, a number of women died, and this is averaging about 551 maternal deaths by 100,000 live births compared to the global number, which is about 223. And so the high number of maternal deaths in some of these areas reflects indeed the inequalities that we have seen between the rich and the poor. Next slide, please. What are the causes of these women dying? So mostly women die as a result of complications that may happen during pregnancy, as well as those that may happen during childbirth. We also have complications that may be as a result of, that may occur during postpartum period. But these complications are mostly preventable and could be treated if women had quality access to quality services. So the major complications that account for women dying, which is approximately about 75% of all the maternal deaths, include severe bleeding. So this could include antepartum hemorrhage as well as postpartum hemorrhage. But mostly we see that women die because of postpartum hemorrhage. bleeding that comes after childbirth. Infections are also a major culprit in terms of the number of women that die as a result of complications from infections. We have preeclampsia and eclampsia also accounting for a number of women that die during pregnancy, also including unsafe abortions. So for us to be able to address maternal mortality, we need to have interventions that will deal with the major complications that we have around hemorrhage, infections, hypertension, or rather high blood pressure during pregnancy, as well as postpartum. Also have to deal with safe abortion. We need to emphasize that we work on policies that encourage safe abortion. And also other reasons why we see women dying is because a number of women have limited access to quality healthcare. So we see that in a number of low-income countries, especially those that are living in the most marginalized or underserved communities, access to quality healthcare is a bit of a challenge. And so there's a lot that needs to be done for us to be able to address this. Poverty also contributes highly. It's a major barrier for women accessing health services, as a number of them need to get out of pocket money to be able to travel to the facilities to access health services. And this is proving to be a challenge. We have a number of cultural practices and norms that may affect the quality of the maternal health for women and girls. And so we need to have interventions that will address the cultural practices such as early marriages, as well as childbearing. So a number of strategies need to be implemented for us to be able to reduce the inequalities and improve the investments for women's health. And this is very crucial for us to be able to advance the global progress in terms of what we need to do in terms of reducing the inequalities when it comes to access to maternal and child health. And some of the targeted strategies include improving access to healthcare and access to quality services. And this can be achieved by ensuring that every woman has access to healthcare regardless of their socioeconomic status, and also ensuring that they have access to essential healthcare services. And this can be achieved through implementing universal health coverage. We also need to ensure that we strengthen strategies, or rather interventions at community level. This will help us to establish and be able to support underserved populations who are really affected by this problem. And so there's need for us to improve and the access to primary healthcare. So interventions at community level need to be strengthened. We need to also emphasize on the importance to make sure that women have access, or rather we need to increase access to family planning services to ensure that we have women who are empowered to make informed decisions around their health, and also be able to ensure that we implement policies that ensure access to self and legal abortion in order to protect the women's reproductive health, and also be able to reduce the maternal mortality as a number of deaths as a result of unsafe abortion. It's also very important that we implement interventions around comprehensive sexual education, particularly for the girls in school, and also come up with interventions for girls that are out of school, for us to be able to empower, or rather provide accurate information about reproductive health, family planning, and also how to prevent sexually transmitted infections. Public awareness campaigns have proved to be interventions that have helped us to raise awareness in terms of what issues we need to discuss around women and girls' health. And also this helps us to focus, or rather dispel any myths or stigma around maternal health. International collaboration is also key, and this can be achieved through global partnerships. And importantly, what's very important is for us to have platforms like this where we share best practices, resources, be able to share resources and be able to leverage on resources that are available within our countries, and also to be able to to share the expertise between developing and developed countries. Also, global health initiatives have been significant in trying to help that we have interventions or initiatives that basically target women's health and maternal mortality. I have alluded to the fact that we have a number of cultural and social barriers that affect the maternal health, and so it would be very important for us to be able to provide healthcare workers with trainings that help them to address the diverse cultural norms and social barriers that we may be having, or rather that may be affecting women. Community engagement programs have been a good platform for us to be able to identify what communities think would be interventions that will be able to assist them, or rather be able to improve or rather reduce maternal mortality. And so it will be very important for countries to develop programs that engage communities to be able to challenge the harmful practices that we have seen, or rather be able to promote positive health behaviors. Investing in operational research is key, because this enables us to be able to understand issues around disparities and also maybe specific needs of certain populations, particularly the most marginalized. And so for us to be able to achieve this, we need to have an increase in funding towards research. And this will help us to highlight issues that may help us to come up with interventions to reduce maternal mortality. We have a number of countries that have been implementing mobile health, or rather mHealth interventions and applications, and these are also very key to help us improve health access and also help us improve information dissemination. And particularly, it also helps to have remote consultation in places where you do not have the expertise that is required. Policy and legal reforms are essential for us to be able to address the challenges around maternal mortality, and therefore it is key for us to be able to advocate and implement gender-responsive policies that address the different or unique needs of the women, as well as issues around the workplace and issues around child care and support. Legal reforms are necessary in the sense that we need to have women's rights protected, including reproductive health rights, and ensuring that the legal cases around gender-based violence are addressed. Capacity building, or rather having a workforce that is empowered, is key to reducing maternal mortality. And this requires that we invest in the education and rather the training of healthcare providers for them to be able to have the capacity to provide quality maternal and women's healthcare. It is also very important that from all the work that we do to ensure that we have a robust data monitoring system, this will help us to be able to collect and analyze information that is disaggregated, and particularly highlighting which population is mostly affected by these interventions. And it's also very important for us to continue evaluating our interventions, for us to be able to see the effectiveness of the interventions that we are implementing. And so by implementing these strategies, countries and organizations can work towards reducing inequalities and improving investments in women's health, and thereby driving the agenda of reducing maternal mortality. In conclusion, for us to be able to achieve a global maternal mortality rate of below 70, which is the target for SDG 3.1 by 2030, we need to reduce the maternal mortality an annual rate of about 11.6%. And this has rarely been achieved by any nation. And so it will be very important for us to put in, or rather coordinate efforts to be able to mobilize, strengthen interventions at global, regional, national, and community level for us to be able to end preventable maternal mortality. And also it will be very important for us to address the women's health and mortality because this requires a comprehensive approach. And basically here we're looking at ensuring that we have healthcare access, education, we have policies that will address the inequalities that we see. And also we should be able to strengthen international collaboration. And to just conclude also by saying that for us to be able to reduce the inequalities and improve the investments in women's health, we will be able to drive and progress and achieve better outcomes for our women globally. And this ends my presentation. Thank you all for listening.
Thank you very much, Cindy, for taking us through your presentation. Cindy went through very alarming statistics, especially as far as maternal mortality is concerned in Africa. She also gave us some global statistics, but she emphasized that maternal mortality is concentrated in the poorest part of the world, which oftentimes is Africa and maybe some other parts of Asia. So in Africa, risk of death is far higher from maternal causes than in high-income countries. Of course, she also emphasized that the causes are mainly due to hemorrhage and eclampsia. But beyond medical causes of maternal death, Cindy emphasized that poverty, as well as cultural practices that are very harmful to women's health, and limited access to services are really the key drivers of maternal mortality in Africa. So we prefer that we need to focus on universal health coverage to ensure access to quality care. And she also emphasized the importance of international collaboration, like what is happening here today, which I believe will take some learning away to our different countries. And apology for that technical hitch. So just requesting that panel should please register and indicate your country where you're joining this webinar from. So I'd like to invite Dr. Milola Olorun, who will be talking to us on principal policies and practices of maternal mortality reduction in Africa. Dr. Olorun, over to you, please.
Thank you very much. Good morning, good afternoon, good evening from wherever you are. Can I have the slides, please? Thank you very much. It's a pleasure to be here, and I'd like to crave your indulgence because I think my audio is better when my video is off. Next slide, please. So by way of an outline, I will start with a general introduction, and then I'd like to answer some questions today. Why do mothers die? How do we document maternal deaths in Nigeria in particular? Why should we care about civil registration? How is maternal mortality measured? And given the time, I will only talk about maternal mortality ratio. What can we do to reduce maternal deaths? How can we leverage data for policy and programmatic decision-making? Next, please. We often speak about women with respect to their reproductive role, and we often forget that women are much more than mothers. Maternal health refers to the health of women during pregnancy, childbirth, and the postnatal period. But we must always remember that women's health is much more than just maternal health. Today, we'll be focusing on maternal mortality, which according to the World Health Organization is the annual number of female deaths from any cause related to or aggravated by pregnancy or its management, excluding accidental or incidental causes during pregnancy and childbirth or within 42 days of termination of pregnancy, irrespective of the duration and site of the pregnancy. Next, please. So why do mothers die? The previous speaker has done justice to this. I'd just like to stress, according to the World Health Organization, most maternal deaths are preventable with timely management by a skilled health professional working in a supportive environment. And I'd like us to keep this in mind because I will talk about this issue of prevention as we go along. Next slide, please. So how do we document maternal deaths? And I'm focusing on Nigeria for most of my presentation. So when a mother dies, and we've already defined what maternal deaths are, usually the information comes from the health facility or hospital if she died in a hospital. Alternatively, it would come from a relative. And it's important to make sure that all maternal deaths are documented as soon as possible, but definitely within 48 hours. There's some information that's required regarding the disease as well as regarding the death itself for the registration form. In addition, the place of registration of death is something many people, especially those who do not know much about the healthcare system because they avoid it, don't know. And so it's important for us to be reminded that there's a civil registrar's office where maternal deaths should be registered, especially if it did not take place in a health facility. The National Population Commission in Nigeria is the official authority regarding registration of vital events, including deaths. And Nigeria's CRVS and health information systems, like those of many other places in sub-Saharan Africa and the low and middle income countries, is generally weak and grossly incomplete. And so it doesn't provide an accurate assessment of maternal mortality, but it's the best that we have most times. Next, please. Nigeria requires the documentation of maternal deaths. We have a compulsory registration act for births and deaths. It's dated 1992, and yet we're still struggling with having births and deaths registered in this country. Next slide, please. This next slide shows the death registration form and what the death certificate looks like, as many people may not have seen this before. Apologies for the shift in screenshots, but there should be two separate documents there. So this is what the death registration form looks like, as well as the death certificate for Nigeria. Next, please. You might ask, why should we care about civil registration? According to UNICEF, civil registration promotes efficient government planning, effective use of resources and aid, and more accurate monitoring of progress towards achieving the Sustainable Development Goals. We know that death registration is important because when people die, especially those who do not have a will, but in general, death registration and the certificate that's given thereafter is very useful for the purpose of inheritance and for sharing benefits of the deceased, whether this is with respect to insurance or work benefits. Death registration is also very important to measure progress against global and country country-specific targets, and we often refer to the Sustainable Development Goals. Death registration is important to assess the impact of whatever interventions have been put in place at the country level or even at the subnational level. And death registration is important to understand what else needs to be done. Once you see that more and more people are registering and you know the causes of death, it helps to make decisions and to plan. This slide shows the maternal mortality ratio estimates by country in 2020. And if you look at the color coding, you will see that Nigeria is one of those countries that has more than 100 maternal deaths per 100,000 live births. And this is between 2000 and 2020. So Nigeria is not doing well with respect to maternal mortality ratio. And in fact, most reproductive health indicators, we're not on track to meet the SDGs by 2030. We need much more advocacy to ensure that our leaders hear this very important message. If you look at the rest of the world and you look at Nigeria, you'll agree with me that we're not doing well. So the previous speaker had given this stats, but just to stress that every day in 2020, almost 800 women die from preventable causes related to pregnancy and childbirth. But nearly 20%, that's nearly 1 in 5 of these, are deaths from Nigeria. Next, please. So these stats are like having a plane crashing, and yet we're not saying much about it. So what can we do to reduce maternal deaths? All of these that you see on the screen have policy and programmatic implications. We have a lot of data available from Nigeria from multiple sources. There's the DHS, Demographic and Health Surveys. There's the Performance Monitoring for Action Study. We have MIX, and we also have multiple online options for obtaining statistics that are country specific. And so what we need to do is to make sure that this information gets to the right people who can make change, who can bring about change. I will just gloss over this because the previous speaker has alluded to most of it. But we do need to ensure that women have access to modern contraception, access to emergency obstetric care, access to skilled attendants at birth. And by this, I mean those who are trained to take deliveries. It does not include TBAs, traditional birth attendants, but it definitely does include nurses, midwives, and doctors. It's also important to ensure that we improve quality of care, and I'll speak more about this, is why I have it in bold. Training and retraining of health workers is extremely important, and the previous speaker also alluded to this. We need social and behavioral change interventions at multiple levels, because sometimes it's not just having policies and getting the information out there, but ensuring that the information is digestible and actionable for the different groups that they're targeted at. And of course, especially in Nigeria, we need more funding for the health sector. Next, please. So to focus on improving quality of care, we know that many times when women go to our health facilities in Nigeria, they do not get the kind of care that they would have hoped to obtain. But pregnant women should receive the right care at the right time. They need to go for antenatal clinic visits because there they hear much more about ensuring a healthy lifestyle, preventing disease, and they hear about family planning for the postnatal period. But unfortunately, based on data which I do not have the time to present today, but which is readily available, the Method Information Index shows us that many women are not receiving the information they should obtain when they go to health facilities. They're not receiving the kind of care they should obtain. The attitudes of health workers often leave a lot to be desired, and that discourages women from going back for subsequent visits. So it's very important that health workers make sure that they receive women in a way that will encourage them to come back. Our health facilities, especially in Nigeria, typically do not have the most appropriate physical environment. They're not welcoming places, and this affects the quality of care that can be provided in these health facilities. Many times, health workers are not able to communicate adequately with women and their families. And sometimes, even when they do communicate, it's not effective communication. Women who come in pregnancy oftentimes come a little anxious because they're not sure what to expect. But effective communication by the health worker helps to reduce some of this anxiety, and it makes childbirth a positive experience for all those who come to the health facility. And so just stressing the importance of quality of care at all levels. Women should not be subjected to harmful practices during labor, such as shouting on them, such as beating them or slapping them, or telling them to be strong when it's obvious that they're struggling. We need health workers who are more accommodating, who are able to support these women through the very difficult event of pregnancy, childbirth, and the early postnatal period. Also, our health facilities need to have these health workers who not only have the right attitude, but they should be well motivated, they should be well trained and have retraining exercises as well. And this is a big problem in Nigeria with our ongoing Japa phenomenon, with many health workers leaving, and those who are left behind do not feel motivated to do much because they're carrying on a heavier load because their colleagues who have left have not been replaced. And I know it's not just Nigeria. Many low and middle income countries are struggling with this now as people seek greener pastures. If you have well-motivated, well-trained, and retrained health workers, the quality of care they will offer their clients, their patients, will definitely be improved. Timely referrals are something else that we often overlook. Whenever a health facility and the health workers therein know that they're not able to support a woman, it's important for them to refer as quickly as possible. Next, please. So to sum up, we know that maternal mortality is unacceptably high. We know that most of these maternal deaths are preventable, and they're coming from low and middle income countries like Nigeria. The previous speaker had already alluded to very clear strategies that can be used to address maternal mortality. And in Nigeria and in many other low and middle income countries, many of these strategies are backed by policy. The problem is implementation. The support, the funding, the guidance to be able to implement these strategies is often missing. Next, please. So here are my recommendations. First of all, we need much more funding for maternal health, and I'm focusing on Nigeria now. At the federal level, at the state level, at the local government level, there's a lot of data available in Nigeria. The problem is we often do not distill this data for the policy audiences that need them. And so I'd like to challenge organizations as well to ensure that they introduce advocacy when they reach out to the policymakers and provide things like two-pagers, briefs that can be distilled by very busy policymakers that state the problem clearly, the implications of the problem, and their recommendations so that they can actually have actionable data. Secondly, in Nigeria, we must reduce donor dependency on contraceptive procurement. Availability and access to family planning information and services has already been mentioned as a way to address maternal mortality. But if we're fully dependent on donors for contraceptives in our health facilities in Nigeria, it makes it very difficult to have a sustainable system. And that's probably one of the reasons why we still have not been able to overcome the problem of stockouts. And so I recommend that states should procure contraceptives and consumables to supplement whatever they receive from the federal government, which we know in Nigeria is largely from that donated from international donors. And so states need to be able to use some of their funds to be able to procure contraceptives and consumables to supplement what they receive. And then thirdly, and this has been mentioned as well, we need to make sure that with respect to universal health care, contraceptives and maternal health supplies are a very important part of any basic package, and they should never be stocked out. Next, please. I thank you very much for your kind attention. Over, sir.
Thank you very much, Dr. Fumi Olaolorun. She promised to answer one question, but she ended up answering two very strategic questions. The one she promised to answer was, why do women die? Why do they die? And she also proceeded to tell us what to do to keep them healthy and keep them alive. Thank you so much for this. She made very critical emphasis on importance of civil registration. And in this case, we're talking of death registration, which could be used to inform programmatic decisions. At the end of it, she made three strong recommendations on funding, the need for us to use available data to inform investment into the women's health, reduce donor dependency, particularly on family planning procurement. And like Cindy emphasized, she also emphasized universal health coverage. Thank you very much once again. I just got a message from the Honorable Commissioner of Health, Sokoto State, that she'll be joining us. Talking to us on reducing maternal mortality, what works, and the way forward from our experience in Kaduna State. Honorable Commissioner, Kaduna State, over to you, please. Thank you.
Sorry, good morning. Permit me to not use the video because my audio is more audible, or my connection is more audible when the video. I'm representing the Honorable Commissioner. My name is Dr. Salima Mohammed, the State Program Manager for Reproductive, Maternal, Newborn, Child, Adolescent, and Elderly Health in the Ministry of Health. So I will take the presentation on the prospects and challenges of reducing maternal mortality, what works, and the way forward, with a focus on the role of family planning and how the family planning program can be tailored to the specific needs of the different communities. Next slide, please. So these are the contents. This is what I'm going to go through. So for the introduction, the use of modern and conventional family planning commodities for contraception saves lives by preventing maternal and infant mortality and morbidity associated with unintended pregnancies. Limited access to family planning commodities is a contributing factor to unmet needs for contraception by over 225 million women of reproductive age, which is the WRA, in developing countries that are not using effective contraceptive methods. Access to contraceptives is recognized to play a key role in the achievement of national and international development goals, including the Sustainable Development Goal 3 and the Family Planning 2030 targets and objectives. So the way forward, next slide, please. Yeah, we've realized that what works. We have done a research here, and we realized that there are a number of things that work for us. Now, number one, the increased sensitization and awareness, especially in rural communities. We realize that if we don't go into the communities and sensitize them, orient them on what is happening or what family planning means, they won't even try to uptake it. Like, for example, the languages we use in different parts of this country differs. Like in the North, you can't come and talk about family planning. You're trying just to say that you're trying to stop their women from giving birth. So you have to use a more technical term like child spacing, which is more acceptable. Okay. So we've realized that increased awareness and sensitization improves the demand generation. There is a program currently working with Adolescent 360. They are from 5 states. Ogun is part of it. Kaduna, Jigawa, Kanu, and Nasarawa. Yes. So they are trying to do demand generation, especially for our adolescent girls. And there has been an increased demand generation from adolescent girls to take up family planning, but this only includes the married women. Because if you go to the northern community and say you are doing increased awareness for adolescent ladies who are not pregnant, they're going to push you out of there. Then the availability of free family planning commodities. There was a time we did an outreach, and within 1 month, we were able to reach 150,000 women with family planning commodities because of availability. It was available, and even if they come, when we did outreach, they came to the facility, it was still available. We usually do outreaches 2 to 3 kilometers away from the facility so that they know that there is family planning commodities there and they go there. There's a sustainable system of conveying commodities from down to last mile. Sometimes we have the commodities and we have the supply chain. The supply chain really helps to distribute these commodities appropriately to where they are supposed to be distributed, to the family planning services center. Then increase healthcare workers and the family planning services capacity across all facilities. Someone mentioned the Japa syndrome. Yes, it's happening in Nigeria, more so in the north. Everywhere in Nigeria, there are a lot of doctors going there. Some hospitals are even closing down wards and units because of the unavailability of healthcare workers. So we try to build the capacity of the healthcare workers we have. Some you build them and they do attrition. So we try to do task shifting, task sharing policy, so that even if one person goes for training, we try and train the other. So it has worked well. The state we work with private sector as well. So we have identified the PPMVs, which are the pattern medicine vendors, and private facilities who also give family planning services, so that we can expand the scope of the family planning services. And we have developed also a system to conduct on-the-job training. So apart from training them in the classroom session and having clinical sessions, we have also realized that going to the facility to do on-site on-the-job training, mentoring, coaching, it works for them. Next slide, please. We've also listed high practices we have identified. We have community health extension workers that are within the community level, and we realized that if we train them, they're going to help us move family planning program forward, because they are the ones living within the community. They don't have the Japa syndrome with them yet, because probably you don't have the qualifications that they need. They have realized that healthcare workers flourish well outside the country, so people that have the good qualifications usually try to move, but these ones usually we try to retain them. Then outreaches and inreaches, like I responded earlier, I gave an example where in 2019, within 1 month, we were able to reach 120 women with outreaches. So if we try to do an outreach and an enrich within a community, it will increase our MCPR by 37% in 5 years. And that's a very good one. Then postpartum family planning and demand generation have been identified. Because we realized that a lot of women after giving birth we're trying to do a demand generation for them so that they won't get pregnant within the next 2 years, so that they can have the bonding between mother and child. She's going to flourish back to normal. Next slide. So we have bottlenecks that we have identified as well, where we have the problems. We have inadequate capacity of service providers. Like I said, we train people, Japa syndrome happens, and they leave the country, they go and flourish somewhere. We realized that here in Kaduna, I'm going to give an example, there was a drop from 714 facilities that are providing family planning services to 319 or so who have dropped from the family planning. Ideally, 714 services, facilities, people were trained for family planning services, but they dropped to 300 to 400. So you see that's very poor. So we need to, which brings me to the next step, which is poor task shift sharing, poor task shifting. Yeah, you learn, but you don't assign tasks or you don't share. We also have an issue with the step down training. So we're trying to see how can we work on the step down. Then a drop in facilities providing family planning services, which is also the same thing that I've been saying. The logistic tools, which are also not adequately printed, like the patient card, family planning register, daily consumption register, review and request form. Sometimes they are unavailable. Poor sensitization and awareness. Yes, we have tried to sensitize all communities, but we have not gone up. As we all know, we have security challenges, we have issues with roads, network, and all. So this we need to work on. The lack of cash backing. We have issues with cash backing. Money will be released for activities, funding will be released for activities, but cash backing, the money will be nowhere to be found. So we are trying to work with CSOs, government. Then next slide, way forward, we have increased awareness and inspiration, training master trainers who can go down to the community level and train others, scale up training of service providers to other facilities, saturate the service delivery providers. We also work with CBOs, community-based organizations. We also work with CSOs, which are the civil society organizations, which help us advocacy to get more funding for family planning. They identify ways for last mile distribution. Like I said, we may have the family planning commodities, but we have issue with transportation of the services to their facility level. In conclusion, next slide. Hello, next slide. In conclusion, family planning would reduce the national maternal mortality of Nigeria by 30% if there is proper uptake, which is saying a lot because Nigeria ranks one of the highest in contributing to the global maternal mortality. Then awareness and sensitization play a key role in acceptance of family planning across communities. Thank you very much.
Thank you very much, Dr. Salima. We appreciate your presentation. Dr. Salima was able to inform us of what works, their own experience in Kaduna State. And among other things, she emphasized health promotion and health education to increase awareness, especially in the rural areas which are not common in most parts of Nigeria outside the capital cities. She also emphasized the importance of sustainable system for last mile distribution to prevent stock out of family planning, commodity at the service delivery points. A few of the high impact practices in their own experience in Kaduna include there were some bottlenecks, as you mentioned, especially around availability and capacity of service provider, and specifically poor implementation of tax shifting tax sharing policy, as well as poor funding. This not because the budget does not appear good, and regard to the Honorable Commissioner of Kaduna State. Before I invite the next presentation, let me appreciate the presence of the former Minister of Health, Zambia, who has taken time to be with us at this webinar. Thank you so much. So at this point, we should be having the Honorable Commissioner of Health, Kaduna, Sokoto State. Is the Honorable Commissioner of Sokoto State ready with us? He pledged to be here by 12. So in absence of that, we proceed to the last presentation, which is going to be on the roles of development partner in women's health in Africa. International collaboration has been mentioned as a very important strategic approach to reducing maternal mortality in Africa. So let us hear to Dr. Ben. Let's hear from Dr. Ben what the development partners have to bring on the table in Africa for us to reduce our maternal mortality. Dr. Ben, over to you.
Thank you so much, Dr. Afalobi, the moderator. And I would like to say thank you so much to the fellow speakers who have wonderfully made presentations very innovative and have really raised wonderful insights regarding maternal health, the maternal health terrain in Africa at large. My name is Dr. Ben Chwidige. I come from Uganda, specifically from the part of Africa. I bring you greetings from the part of Africa. Briefly about me, I am currently the managing director or the general manager for St. Peter's Hospital in Chanja, one of the major towns in Uganda. And from that background, a very passionate maternal health advocate who have been in practice, advocated for some time regarding pushing maternal health deliberations from the policy level up to the community levels across the different divides of my country, but again, even in Africa as a whole. I happen also to be the global co-chair for the Pediatric Adolescent Violence Elimination Committee as well board that sits, that advises the NIH on the issues regarding HIV cure interventions for the adolescents. But away from that, I am speaking about a topic that is very passionate and very close to my heart, and that is maternal health commodities. The pre-current speakers have really done justice to the topic, right away from Cindy, Dr. Familora, and the pre-current speaker who has represented the Honorable Commissioner of Health from Kaduna State. I want to appreciate them. They have done justice to the different statistics regarding the maternal health, kind of terrain in Africa. And I want to speak specifically on the role of development partners. And it is very evident that very many speakers have already alluded to it. We are seeing statistics that are very worrisome. Having 430 women die per 100,000 live births in Africa, more so in the what we call the LMICs, the low and middle income countries where Africa is. I always have a perturbing word. They call us countries from the global north, and indicating that we are countries that are coming from very poor or countries with a very poor background. So that simply means there is already an issue of finance in the picture. And Dr. Familola has spoken about the leading causes, and actually even Cindy, the key leading causes of maternal health mortalities in the country, one being PPH. We do have poverty. Obvious case, I can speak about the 3 delays that have really, the 3 Ds protocol that has really caused a lot of women in Africa, in the different countries. I've already seen the statistics in Nigeria are very worrisome, but even in Uganda, but there is a little bit of improvement in my country, according to the recent UDHS that has been released. That is the Uganda Demographic Health Survey. We were losing 330 women per 100 live births, but I think from 2020 reports that has been released, we've come now to 300 statistics that are still worrisome. And when you try to kind of test the background, what is really causing all this, finances, the role of development partners, the role of civil society, the role of the different stakeholders comes into play. So in the next slide, I want to speak to the different policies and the different, commitments that are made across the different, parts of Africa. Our countries are signatories to the different, commitment papers, to the different declarations. I can speak about the Agenda 2063 that really wants to make sure that we have the Africa we want. The 2030 Agenda on Sustainable Development Goals that really puts it right on how we can make sure that we enhance and actually have proper maternal health outcomes in the continent. Sexual reproductive health continental policy, obvious case, we all know the revised Maputo Plan of Action 2016 to 2030, where the key thing I want to bring out is the different figures, the specification that we are supposed to allocate in terms of budgetary allocation regarding the health budget. I'll give you a snapshot of my country. In my country, the Maputo Protocol states that we should allocate 15% of the health budget of the country's budget should go to the health. It should go to the health budget. What does that mean? In my country, we are at most 8%. We've never even reached 10. I don't know what the figure of Nigeria, the profs here will tell us, but it is still way below the belt in terms of the maternal health, appropriation in terms of budgetary allocations. We also continue to speak about the AU Abja commitments, where countries, Nigeria being inclusive, are signatory to this. But again, we also look at what we call the Global Strategy for Women's Health, Children and Adolescents, 2016 and 2030. All these declaration documents and policy guiding documents are already giving us a strategic direction on how best we can have a strategic direction in terms of improving the health systems in Africa as a whole. So what does that simply mean? It simply means that we as stakeholders, civil society, academia, government, we need to find a way of having an accountability mechanism. If a country goes and signs on a different declaration, does it stop on appending signatures on the papers, or we even follow up as civil society, as academia, to hold our governments accountable, so that we know the world that if at all we want to achieve the Agenda 2030, my sister spoke about the universal health coverage, we are in the areas of self-care. How are we going to achieve this? Next slide, please. We can only achieve this if we have deliberate efforts by the different governments and states in appropriating funds. I didn't want, next slide, please. We have a problem right now of donor dependence, and one of the speakers alluded to it. Many of the countries in Africa, we overly rely on donors. And to me, I think it stems from lack of political will from the different governments, even if to those who do have the political will. But again, how many of the countries are able to sustain their budgets? So we do have lack of prioritization in terms of the different health, allocations regarding the budgets and all that. So it simply means that if we do have issues regarding appropriation, then it means that our health budgets are going to be jeopardized. We are going to have issues around the human capital development, low staffing levels in the health facilities. Then we're not going to have enough money that is appropriated towards buying health commodities. We've heard very well from the pre-current speakers that very many countries, we are over-relying on donors to, even purchase family planning commodities. It's across very many countries that FP commodities are largely coming, the support is coming from donors. So that simply means that there is either low prioritization from our countries. Yes, we might not have the muscle to foot all our budgets, but again, if there is enough commitment from the different, governments, states, and different partners within the country, I'm looking mainly at the domestic appropriation of funds before you even look at outside the donor. But what could be the role of government partners? I understand they do play a lot of crucial roles in women's health, one of them being funding. And I've already spoken ever since I started my presentation, the pre-current speakers have spoken about that. Funding is a key issue. Very many health programs, maternal health programs, family health commodities, provision of post-abortion care commodities, many funders have come on board, to provide that. Very many countries are a bit technical and skeptical in providing some of, those commodities. For example, if I speak about the PAC, programming, the post-abortion care issues, many countries are still fixed and they do not have those services really outlined in their countries. But again, also development partners help us in providing technical assistance in line with programming, and also the non-government organization help in designing and implementing effective programs, because I know civil society organization and other development partners are the ones that keep the government in check, providing accountability, and also what the government has not done properly, civil society comes in and, and other development partners to patch in and also providing an alternative, kind of solution to what the government is giving. Next slide. But again, there is a lot of work that is being done in terms of advocacy. Very many development partners, society organization, academia, and other in other partners have done really important and very vivid, advocacy in terms of policies, in terms of programs that have yielded into positive programs that have hoped to improve the maternal health indicators. If at all want to reduce the 11.6%, achieve the 11.6% reduction of maternal health, mortalities across the entire globe, then we need to, have all, stakeholders working holistically together to see to it that we improve that. But again, we should also have, there is a lot of collaborations between development partners and the governments, non-government organizations, stakeholders to make sure there is promotion of women's health. In summary, development partners play a critical role in promoting women's health by providing funding, technical assistance, advocacy, and collaborations. By that, I want to say that this is a well thought about webinar. But key to note that if at all our governments come on board, there is political will with the advocates, the academia, people who are leading programming in these different countries, we can really work towards achieving the universal health coverage, making sure that SDG 3 is prioritized and the health of women is brought to consideration and prioritized. Issues around Maputo Protocol, who is doing the accountability? Are we holding our countries, accountable? We have issues of health insurance across the different countries. The picture is totally different. But again, if at all we also want to increase the per capita government health, expenditures and all that, we need to have these discussions ongoing in the different, spheres we present in or we speak in. So with that, I would like to, the next slide, please. I would like to say asante sana. Thank you so much. Mwebale nyo, that is from my country. I would like to say for God and my country, for health I serve, I beg to submit. Thank you.
Thank you very much, Dr. Ben. That was quite very instructive, very useful, very informative from Uganda. And I also thank you for the kind words. You alluded to the fact that this is one of the best webinars to come up at this time. When Dr. Ben started, he mentioned policy environment to support the Africa we want. And he came down on a few of such a policy regional framework that exists in Africa that all the countries here are signatories to, like Maputo Protocol 2016 to 2030, Abuja Declaration of 2002. And all these have been guiding lots of what we are doing, but are we really doing enough in our different countries? That's a question we need to answer. Then, on partner or donor funding. And that appears to be the experience on family planning, procurement, and distribution in many parts of Africa. They went ahead to add technical assistance as well as high-level advocacy as part of what development partners could bring on the table to support Africa reduce maternal mortality. Of course, there are some further collaborations on women's health that could be of support from the development partner, according to Dr. Ben. So once again, thank you. I want to thank all the presenters. It's really been a very exciting moment. And now we will open the floor for questions. There is a question and answer chat that gives you the opportunity to send your question into that chat box. Please do so while we are discussing the questions that are currently on now. Dr. Lucky Palmer, thank you very much for your question. I think I should read this out. Dr. Fumiola Lorno has addressed the question. The question is on safe abortion, which Dr. Lorno mentioned as one of the major causes of maternal death in Africa. And Palmer Lucky wants to know, what are the recommendations for this? Dr. Lorno addressed the question by saying that one important way to avoid unsafe abortion is to use modern contraception to avoid an unplanned, unwanted, or a mistimed pregnancy. And another one is to provide safe abortion services that must be within the ambit of the law of the particular country. I don't know if Dr. Lolo wants to elaborate a little more on this for just a minute or so.
Thank you very much, sir. I think the issue of safe abortion services is one that's really interesting and is probably a webinar all on its own. I know that Lagos State has tried to expand the indications for safe abortion beyond saving a mother's life in Lagos State, and it has received quite a bit of resistance from some members of the community. So I think what I would like to stress is, if this is something that Nigerian researchers and advocates and program leaders would like to pursue, it's something that requires a lot of advocacy at multiple levels, bringing in civil society as well as faith-based organizations, so that people understand, because abortion is still a very sensitive topic in this country. And it's important to do things right so that everyone who needs to be on the same page of the same book will be there and will understand the process. And therefore, we will all be able to arrive at new legal guidelines that will be acceptable to all. Thank you, sir.
Thank you, Dr. Fumilola Lauren. To Kaduna State, the representative of the Honorable Commissioner of Health, I have a question for you. You know, in Nigeria, once we have improved a budgetary provision for health, they're happy. But that's not the end on its own. The end is on ensuring release and utilization of such funds as appropriate, especially in line with what the budgetary provision has indicated. But you emphasize the issue of cash backing, lack of cash backing as a major problem in Kaduna State. What measures are you taking to ensure that we have cash backing for appropriated funds to health? Thank you, and over to you. The representative of the Honorable Commissioner of Health, Kaduna State. Okay. So while we are hoping that you come on and respond to that question, there is another question in the chat box from Daramala. Yes, Dr. Salima, go ahead, please.
My network went off. I didn't hear the question. Sorry.
Oh, so the question is on lack of cash backing that you mentioned as one of the major bottlenecks.
Yes.
So what measures are you taking to ensure that we have cash backing to appropriated funds?
Okay. All right, let me give an example. This cash backing was done in 2020. 250 million naira was approved for release for family planning commodities as of that year. It will surprise you to know that up till now, that money has not been released because of lack of cash backing. So we're working with the CSOs and the government, the civil society organizations and the CS, to discuss this with the government. And we have reached an agreement with the government that every month they're going to be releasing 20 million naira for family planning commodities, which will amount to that 250, 40 to 60 million naira, depending on how much they want, with the hopes that when they see how effective the family planning services are, they would continue sponsoring it. We tried to, there's a National Basket Fund where we pull money inside. We had a training recently. The UNFPA usually supported the program, and Gombe was one of the first people that implemented that, where we pull money from our state and put it into the National Basket Fund for procurement of this family planning commodities. So the way forward is working with the civil society organization, and we have achieved that. But the problem now is when the money is going to drop. So that's where our CSO is coming. But we have been working tirelessly to see how the money comes back.
Yes, thank you very much. I think this question from Mr. Olukule is also directed to you.
Yes, sir.
And the representative of General Commissioner of Health, Kaduna State. Do you want me to read it out for you, or you want to go ahead and respond to the question?
No, kindly read, please.
Okay, so Olukule wants to know what the government of Kaduna State is doing to reduce the number of pregnant women who deliver by unskilled birth attendant.
Okay, thank you for that very important question. We are increasing. we have trained and are training healthcare workers on different aspects of maternal health. Like, for example, we have trained people at the primary healthcare level on emergency obstetric and newborn care. We don't want to train on postpartum hemorrhage and what can be done. There is this package of emotive. I don't know whether everybody is aware of it. It's a training that has been done, or a research that has been done in Nigeria, which has been proven effective to reduce the maternal mortality by more than 50% from postpartum hemorrhage. So we're trying to train people like on that. So there are a series of trainings, identifying, apart from the attrition of healthcare workers, we're trying to recruit healthcare workers and also train them on skilled birth attendant. Right now, we want to also inculcate it into the nursing program, where these people, by the time they are coming out from the schools, they have already been trained on this emergency obstetric and newborn care course, on the neonatal courses and everything. So that by the time they are out from their schools, they are fully equipped and they can be employed into the services and they can render services. So we are also trying to get more equipment, infrastructure, so that women can deliver comfortably in a well-lit, hygienic area. Thank you.
Yeah, thank you very much. I think the last question, though, is not in the question and answer box, but it's in the chat box. And I'll read this out. As many as the panelists want to respond to this can aside from advocacy. So maybe we start from Dr. Fumilola Lauren, and then we proceed to the Commissioner of Health, Kaduna State, and finally, Dr. Ben. Oh, sorry, Cindy. Let's start with Cindy, please. I'm sorry. Cindy, are you there? Hello, Cindy.
I'm here.
Yes. Did you hear the question?
Yes, I did. The question is around the number of challenges that we have, and also government commitment being highlighted as a challenge, and what is being done for us to be able to improve government's commitment to addressing the challenges that we have around maternal health,
Yeah.
other than advocacy. I think a number of times we do talk a lot about advocating for government's commitment, but like we have heard from the previous speaker, a strong political will is very, very important for us to be able to address maternal mortality. Having strong leadership at the different levels of care is key to address maternal mortality. And so it's important for us to continue advocating. I know that advocacy has been put on the side, but I think advocacy is very important. It's the first step for us to do. But also, like we heard from the other presentations, depending on donors, I think is one thing that has really affected how government is committed to and response to some of the challenges that we have. And so if we come up with interventions or rather make initiatives that help us to generate our own funding within our own countries, we're likely to see government being more responsive and being more committed to the challenges, addressing the challenges that we have around maternal mortality. But because most of the interventions are donor dependent, and the governments are not putting in as much, we're likely to see this challenge continuing. But it's a discussion that we need to continue having until we see governments responding. Thank you.
Thank you very much.
Thank you very much, sir. I think it's an excellent question, and I hope that there are people from government who will add to what we're saying and add to the conversation. I think advocacy is linked to everything I'm going to say, directly or indirectly. But I think that we need to engage government much more as researchers, as civil society. We need to make sure that they understand the problems at hand. And we need to be able to work with them in order to be able to find the solutions. Many times researchers work in their silos. They get grants, they do work, and then they try to disseminate to the government after they have information for action. But how about changing the paradigm? How about identifying the problems along with people in government, arriving at solutions together, co-designing interventions, co-designing programs, so that government officials are part of the story from the very beginning. I think that involving them at every step of the way in order to be able to arrive at data for action is something that we have not paid attention to, but an approach that might be useful in engaging them further. A second suggestion I have is that we find out we do some form of stakeholder analysis and find out what these government officials really care about and link it to maternal health. Because if we're able to link the problems that we're interested in with what they're interested in, I think there'll be better commitment and better engagement. And if government officials, important stakeholders who can actually make a difference with respect to policy and programs are fully engaged, then they will make sure that we get the funding that we need to improve the health of mothers so that we do not lose another mother unnecessarily. We don't lose our sisters, we don't lose our daughters. Thank you.
Thank you so very much. The representative of Kaduna State Commissioner of Health, do we have any more from you?
No, I just want to stress on the advocacy. Advocacy is very important, like I told you, because of the advocacy the CSOs have done, we were able to get the sorry about that, which is on the process of being released. So advocacy, advocacy to the community, advocacy to the government, it goes a long way in improving our family planning services, commodities, and program in general, which we hope will reduce our maternal mortality by 30% if uptake is optimal. Thank you.
Thank you very much. So finally, Dr. Ben. Dr. Ben? Is Dr. Ben still with us? Okay, so let's proceed. We really can't thank you enough, all the panelists from across Africa, Zambia, Uganda, Nigeria, and the participants. So I'd like to invite the managing partner of ACRE Associate, Mr. Ekenem Isiche, to give us some final comments and then thank everyone for us. Ekenem, over to you, please.
Thank you, everyone, and good morning and good afternoon your time. Just want to say, first of all, thank you to all our distinguished speakers that were really able to chime in and share their words of wisdom. We truly appreciate it. I think every step, every decision we make must be moving towards the trajectory of how do we help to elevate what's happening within the health landscape and also help to reduce some of the bottlenecks or indicators as we see. With all that's going on globally, with all the global tailwinds, it's important for us to really have a really strong coordinated approach on how we're doing things. So we didn't just think about, our key panelists, just not from Nigeria, but also to bring in an African lens of what's going on. So I really want to thank Dr. Cindy Kirwa from Zambia. Thank you so much for being able to make this. We're going to call on you again and again and see how we can definitely do more in the city of Zambia. I've had I personally have had the opportunity to actually meet with the president. So, and with all the reforms going on, I think Zambia is in a really good place to move things forward. Dr. Fumilola from University of Ibadan, as always, distinguished speaker. Thank you for always bringing your words of wisdom. Truly appreciate it, and even your time, on the Monday. The representative, the representative of the Commissioner of Health from Kaduna State. Your points were spot on in terms of your thinking and what you were sharing. Truly appreciate that. Dr. Ben from Uganda. Thank you so much for also being your words of wisdom. We know about the reforms that have been going on in Uganda, and we also know about some of the tailwinds Uganda has been facing. But I think collectively, as we share learnings from both countries, and Nigeria and Uganda, I think we can do a lot together. So I look forward to doing a lot with you all in 2024. And also, obviously, Sokoto State also being represented here. Thank you so much for all the work that's going on there. And like we said, everything is really a coordinated effort to see how we can move things forward. So this wouldn't be the last. One of the things we're trying to do now is to really, our next set of webinars will probably focus on looking at what's happening in Nigeria with the swap model. I don't know if Uganda and Zambia are doing things around the swap model that Nigeria is considering, but it'd be good to sort of share your thoughts on that as we look in 2024, because that's going to be one key highlight between the first quarter of next year, as the current minister and the new administration is thinking about how they can implement a swap model in Nigeria. And I know that one thing that we're doing at ACIU is to place a lens on that and see how we can, we'll be having discussion around that and seeing how we can really think about this framework and how the framework is going to be beneficial to all parties and really help move the health indicators forward along the value chain, whether it's from the demands or service delivery, on the supply chain efforts. Everything we're doing pretty much has to have an expected end. So I want to thank everyone, on all our distinguished guests virtually. Thank you so much for your time today. Look forward to doing this again in 2024. And feel free to reach out to us if you have any opinions, feedback, or feel like we can definitely help you in some of the work that we're doing. Thank you so much, and have a good one. God bless.